Today I will try with the few minutes I have to go through the few things regarding the DOACs and the antiphospholipid. We'll pass through some facts about DOACs, facts about ABS itself. Then we threw few points about the management of ABS before we end by spending most of the time talking about issues in the diagnosis. Do we have or do we see effect of DOACs on diagnosis? Does it affect the diagnosis of ABS? Issues with the treatment. Can we use DOACs to the treatment of thrombosis in ABS? We all know that DOACs for the last decade had gained a lot of importance and became the main or the first choice in many indications, like what just we heard about AF, non-fulfilled AF. Their favorable results proven in large scale of clinical trials, and there are 5 approved DOACs, including dabigatran, rivaroxaban, apixaban, edoxaban, and betribixaban. The different indications approved by FDA for prevention and treatment of stroke, VTE, is listed, and as you can see that maybe the rivaroxaban, which was one of the first, both dabigatran and rivaroxaban gained the most approved indication, yet the apixaban is gaining now more indications and becoming one of the drug that is commonly used, particularly for those with more bleeding tendency. Edoxaban is stepping towards becoming one of the drugs that can be used, and one of the things that under clinical investigation and approval is the treatment of CAT or cancer-associated thrombosis. Who should not be on DOAC? So we hear that in cardiac there is a lot of tendency to put patients on DOACs and switch from warfarin to DOACs, as many as we see, except in few indications that are not yet approved for DOACs. When it comes to the other side of the DOACs, which is the VTE, we should put most of the patients on DOACs unless the patient has a significant bleeding. So we know that with warfarin, it's easy to reverse, it's easy to control the bleeding. Although there is an antidote for DOACs, yet it's not available everywhere, and still it's preferred if the patient is at risk of bleeding, like in patients with von Willebrand disease who develop thrombosis. It's preferably to be on either parenteral or oral anticoagulant other than DOACs. Those who have hypersensitivity, yet the pregnant and breastfeeding patients should be avoided. Severe renal impairments, although there are a lot of talks about which level of renal impairment we should not give DOACs. We will not go through this today. Liver disease with elevated ALT more than 3 times, and finally antiphospholipid syndrome. And as you can see, there are a lot of question marks, and we'll try today to shed points on the cons and pros in DOACs in antiphospholipid syndrome. If we move to antiphospholipid syndrome, we all know that it's a clinico-pathological entity defined by 2 major components: the presence of the antibodies, autoantibodies, we call it antiphospholipid antibodies, targeted against phospholipid binding plasma proteins, and the occurrence of 2 of the clinical features, either VTE, be it arterial thrombosis, or even peripheral artery, or pregnancy failures. This should be or had been extensively studied. Many classification, the last classification, which was revised in 2006, yet still it is the valid classification which we use to classify and diagnose the patient. And as you can see, both the clinical and laboratory criteria, and to keep eye that most of the laboratory criteria are based on ELISA or antigenic antibody identification, except for lupus anticoagulants, which is a functional test. So if we look at the types of the antibodies, other than those being approved by the or recognized by SABARO criteria or modified SABARO criteria, we can see there are a lot of the antibodies that are associated with the ABA, including anti-prothrombin, anti-annexin, and so many others. The question, which one of the pathological, recently we had just published 2 publications for this one and this one, and we showed significance, yet the number of publications and evidence is not enough to include them in the classification criteria. And we will continue watching the emergence of literature to help to add more pathological antiphospholipid antibodies. As I mentioned, most of these antibodies are ELISA-based, so they are not much affected by other variables because it's a simple antigen antibody binding. So it will depend on the specificity and the sensitivity of the ELISA to detect the presence or absence of these antibodies. Except for lupus anticoagulant, which are a group of antibodies identified by different coagulation assays, they target phospholipid surface. It is better correlate with thrombosis. We know that the specificity of LA is more than the other antibody. It's correlating more with the pregnancy failure. We detect them by ABTT, which usually prolonged, or diluted Russell fiber phenol test, which is the recommended test for screening. The ISTH had recommended at least 2 screening tests and 1 confirmatory of the type of screening to confirm the presence of lupus anticoagulant. There are many modifications in a normal ratio, improve the interferability, integration of some tests within the test, or some components within the test had improved the sensitivity and the specificity of the test. Yet some of the LA tests can be interfered with some of the anticoagulants, including the warfarin. We know that warfarin can affect the diluted Russell fiber phenol test, but not the stack clot phospholipid-based test. So patients who are on warfarin should not be tested using the diluted Russell, yet rather they should be going directly to be tested by the stack clot test, which is phospholipid-based. When it comes to the management of ABS, we know that not all patients with ABA develop symptoms. So we have a group of patients, we call them incidental, where the tests get positive, but they don't have the manifestation. So from literature, from clinical experience, there is no direct evidence that the presence of the antibody can cause disease. And we know that these are antibody going through waxing and waning picture, where it can be positive sometimes, negative sometimes, and the only special recommendation that if you have a persistent lupus anticoagulant or antiphospholipid in a special situation, you may tend to give prophylaxis for those patients if they go through pregnancy or go through surgery where it can be exposed to higher risk for development of thrombosis. The common questions for patients with thrombosis who have antiphospholipid, what type of anticoagulant to use and how to monitor that anticoagulants. If we use warfarin, what is the intensity of warfarin and for how long duration? The use of aspirin plus minus primary or secondary prophylaxis. All these questions, still some of them we know, but many still under controversial between different schools between different schools in hematology and rheumatology, and the physician in hematology looking at the point from different angle, while the rheumatologists with frequently see these patients look at it from different angle. The type of anticoagulants available can be used for the treatment of thrombosis in these patients, can be unfractionated heparin, low molecular weight, fondaparinux, warfarin, and DOACs, which we will talk more in details about the value and the use of DOACs in these patients. If you use these drugs, you need to monitor. So what are the methods for monitoring, and what is the therapeutic range? This is again an area had been killed by investigation. We all know the unfractionated and low molecular weight heparin and even the fondaparinux can be monitored by anti-10A assay, but they are different anti-10A. It's not the same anti-10A because we use different calibrator to that assay. And that is the test of choice for patients who need to be started either on unfractionated heparin or low molecular weight heparin, because we know that the BTT in these patients is start with prolonged. So it will be difficult to monitor patients or adjust the dose. When it comes to the INR, INR is, it was an issue, and the intensity of INR early in 1990s was recommended to have a high INR because the disease has high recurrence rate. Later studies had shown that the standard intensity 2 to 3 is quite enough with good support to stop the thrombosis and avoid bleeding. If we would like to switch now gears to the DOACs and ABS, we can look at DOACs and ABS from 2 points: the effect of DOACs on the diagnosis and the effect of DOACs on the treatment or the utility of treatment. The question, do we see effect of DOACs on diagnosis? Definitely, we do that in clinical practice, and literature had supported that. We know that testing for LA, because it's functional test, it's not antigen ELISA based in assay, it get affected by acute prothrombotic state. So patients with high factor VIII or high even C-reactive protein, they may have a false positive LA. And that's why it is recommended to repeat LA after three months from the first, because that's the time where you can clear the acute phase and relieve the effect of this acute phase on the test. It may be preferable to defer the testing in acute VTE, and that's what being recommended by most of the guidelines. You don't need it upfront, you can do it later and confirm it after that. There is a high rate of false results noticed with DOACs. These results either positive or negative. Again, Emmanuel Farfaro and others had shown that rivaroxaban tend to have increased the positivity of the LA non-specific or false positivity of LA. If you stop rivaroxaban, the patient and repeat the LA after just 2-3 days, the LA tend to be negative. Especially, I would do it with the low ratio, like those who have a 1.3 or 1.4 LA1, LA2. It tends to be frequently negative. The same with some of apixaban is not the same like with rivaroxaban. There are some reports where apixaban affected the LA with a false negative, not false positive. Yet that's not as common as with the false positive. Treatment of ABS is complex, and we had a vast experience with warfarin for a long time. When DOACs came, especially for patients with long term that needs to be on treatment for long time, early stages, DOACs had been used, and anecdotal reports from both sides, positive and negative, had shown that DOACs may be not the ideal anticoagulants for those patients. For that reason, multiple randomized clinical trials, including RAPS, the rifaxiban in antiphospholipid syndrome, TRAPS, the rifaxiban in thrombotic antiphospholipid syndrome, rifaxiban versus VKA in ABS, ASTRO for apixaban for secondary prevention of ABS, and finally a meta-analysis of randomized control trials in 2021, which again looked at large cohort of patients who received the DOACs as a treatment for thrombosis and antiphospholipid. Few other evidence came from small studies like phase 4 pilot study of rifaxiban 20 milligram daily versus, which was completed in 82 ABS patients with prior VTE and showed no much difference. Another systematic review of 728 patients on DOACs, and we'll try to go through the results of quickly through these studies. If we take RAPS, which is the rifaxiban in antiphospholipid syndrome, which was a phase 2/3 comparing rifaxiban 20 to warfarin targeted INR 2.5, 116 patients with first episodes of VTE. The outcome was the laboratory segregate which was endogenous thrombin potential as thrombin generation at the time of outcome, and not powered for clinical outcome. So it was mainly laboratory to see if the patients who are on rifaxiban, they don't generate thrombus or thrombin generation. And they excluded patients with previous arterial or recurrent VTE, the outcome inferiority of rifaxiban to warfarin. So Bingo had shown and published in Blood that, yeah, rifaxiban is not good, so it's inferior to the warfarin. The second study was TRAPS, and it was a larger study, enrolled 536 patients. It was phase 3, and it compared rifaxiban 20 milligram daily versus INR targeted 2.5, powered for VTE clinical outcome, and it was prematurely terminated after the enrollment of 120 patients due to excess risk of thrombotic event seen in subject treated with rifaxiban, with annualized thrombosis rate 7.5. From this study, which was published in Lancet Hematology in 2016, there was like a recommendation that patients with antiphospholipid patients with thrombosis should not receive, particularly those with triple positive antibodies. If we move to apixaban, the only study had published is ASTRO, which was a phase 4, apixaban 2.5 twice daily versus warfarin standard intensity. Study was modified twice due to high rate of thrombosis in patients with history of arterial thrombosis. Patient enrollment and follow-up is completed last year, and still we are waiting for the publication. The systematic review, we have two systematic review. The first one, which was published in 2019, was large systematic review of 728 patients of antiphospholipid on DOACs. Almost 50% of them, they had triple antiphospholipid. The annualized recurrent thrombosis rate of 11%. Another individual patient data meta-analysis of 447 patients reported annualized, again, recurrent thrombosis of 11.7. So all these studies had shown that the DOACs are not as good for prevention. On opposite, still the recurrence rate was quite significantly high, and was recommended not to use DOACs for these patients. Yet, life is not easy, and not all patients behave the same. There are patients who refuse to continue on warfarin because of the complexity of warfarin, or they have problems with warfarin because of the monitoring of the anticoagulant that make them to visit the hospital more frequently, especially those who are in remote areas. All those with low risk of ABS, those group of patients had opened the venue for the possibility of using DOACs. The 16th International Congress on Antiphospholipid Antibody Task Force reported on antiphospholipid syndrome treatment had looked at this, and they had, as been recommended by the studies, recommended the VTK warfarin as a standard treatment for thrombotic antiphospholipid. They had mentioned that there is a lack of consensus regarding appropriate intensity for ABS in certain group, although from both previous two retrospective studies, it showed that both the 3 to 4 versus 2 to 3 are almost the same. So except for those who get a thrombosis on a standard risk, you don't need to upgrade the intensity for patients who are controlled on the intensity. FDA and other regulatory have issued and concerned about the DOACs in antiphospholipid, and some contraindication had been issued about the use of DOACs in patients with ABS. Before I end, recently I had another meta-analysis, large one, of 4 studies were included and published in January 2021, where 23 and 10 thrombotic events recorded among 282 and almost 300 ABS patients treated with DOACs and warfarin. And what they found that in patients with ABS treated with DOACs compared to those treated with warfarin, there was no evidence of higher risk of recurrent venous thrombosis was found, but they found significant increase in risk of recurrent arterial thrombosis. And if you look at those studies, the first 2 studies, they excluded the arterial thrombosis, and yet with those excluded, we see some higher rate of tendency, but which is opposite to what this meta-analysis is reporting. The risk of recurrent arterial, as we had seen in more studies, is much more frequent than the rate in the venous. And from this, they came up that this raised the question of efficacy of DOACs to prevent venous thrombosis in a subgroup of patient or subset of patients with ABS without history of arterial thrombosis. So they made the door a little bit open for selection of particular patients with DOACs who have no definitely arterial thrombosis, who have no triple antibodies, but they may have a low level of the antibodies of one of the antiphospholipid, and those who have problem to keep them on warfarin for long period. In summary, the use of DOACs in treatment of VTE is associated with antiphospholipid requires more clarity, as this condition is associated with increased risk of recurrence. There is no rule definitely for DOACs in patients with triple positive cases. And again, I would recommend, if you have a patient who is on DOAC and you tend to have a low intensity positivity of particularly lupus anticoagulant, you need to repeat it after stopping the DOAC for a couple of days to confirm that it's a true positivity, not a false positivity. With that, I would like to thank you for listening And I stop here.